The next speaker is Dr. Vishal Jhanji, and he'll be talking on advances in dry eye imaging.
Thank you. I'm sorry I'm late. The city's food and traffic both slowed me down. First more than the second one. So I don't have any financial disclosures relevant to this topic. This is going to be probably a straightforward talk, but again, something that we keep on forgetting and we need to remind ourselves time and again. Principles of diagnostics in dry eye imaging is we basically measure the tear film secretion. We look at how stable the tear film is. We look at the integrity of the tear film, and of course there are always lab tests for those of us who work in a slightly sort of more academic center. When it comes to tear film quantification, the most commonly used testing is using tear test strips. They're gently brought into contact with the ocular surface for a few seconds, and basically you can quantify the tear volume. Sherman's test is the most commonly used test. We still use it quite a lot actually in our dry eye Sjogren's clinic, but there are other tests available as well. The more commonly used test in clinical practice is actually the tear film breakup test. We basically look at how quickly the tear film breaks when a patient blinks and you ask them not to blink again. In a more advanced version, you basically do a non-invasive pre-breakup time, and I'll discuss that separately using all these devices that are listed there. You can look at the tear film integrity basically in a similar way. You look at the conjunctival and corneal staining, you note any unstable tear film using fluorescent dye. You can use rose bengal and also lissamine green depending on what is available in your clinic. This is the NEI grading for corneal staining, one of the most commonly used tests in the clinic. Some of us are rather busy in the clinic when you look at dry eye patients, but if you have a proper dry eye clinic, I can assure you this really helps you specifically when you're looking at patients at follow-up visits. You can also use the DEQ questionnaire. It's very straightforward compared to the more commonly and more popular ocular surface disease index, which is basically a positive symptom score on a list of questions that are listed on a form. Presence of any of these three specific signs actually indicates dry eye disease, reduced tear breakup time, can be invasive or non-invasive, any ocular surface staining, whether that's on cornea or conjunctiva in either of the eye, and elevated or large intraocular disparity in osmolarity. This is a picture that shows basically how you can use non-invasive tear film time on one of the devices called keratograph. You can see it actually gives you a visual map. You can actually measure the tear film meniscus height using one of these devices. They're very commonly available now. We do utilize the newer versions of anterior segment OCTs, basically, which is a low coherence interferometry device. You can look at the upper and lower tear film meniscus height. You can actually measure the volume in different areas, especially at the junction of bulbar conjunctiva and the lower eyelid. You basically know the average value of tear film thickness is about 5 microns. In addition to that, of course, you will get an idea about the corneal pachymetry and epithelial thickness mapping, which is gaining more advantage, especially in drug toxicity related dry eye nowadays. And of course, you can use the same anterior segment OCT to image the meibomian glands. Again, a picture showing how you can actually look at the lower tear meniscus and look at the height and the radii in different patients' eyes. The TSAS, or tear film stability analysis, we still have this old-fashioned machine which is actually very useful and quick, gives you 10 topographic images at 1 second intervals. Again, a very easy device to use when you look at the images. Of course, the all green image is from a normal patient, and you can see the TSAS map from a patient with dry eyes. You can use aberrometry. Basically, it's a non-invasive assessment of visual disturbances that can detect dry eye disease, and you can again monitor the efficacy of treatment. So basically, it's the concept is the same. You're looking at the surface irregularity index. So with the increasing availability of devices to treat meibomian gland dysfunction, lipid layer analysis using interferometry has become more common. You're basically looking at color fringes that arise from interference between the light reflected from the lipid layer and the interference between the lipid and the aqueous layer of the tear film There is some correlation between dry eye symptoms and a thin lipid layer, which is less than 60 nanomicrons, and lower lipid layer thickness also sort of portends a higher probability of MGD in a patient. You can do a video recording using the LipiView device, which basically tells you if a patient is an infrequent blinker. And it's not uncommon for patients to look at you in a weird way when you ask them, are you blinking frequently? As I mentioned, MG assessment has become more and more sort of popular and commonly used in the clinics. There are different ways to grade meibomian gland dysfunction. You can actually look at the gland expression. Here's the grading, which is very commonly used. It can be anywhere from a clear meibum to thick toothpaste-like meibum from the glands. You can use meibography, which is basically in vivo imaging of meibomian glands. The most simple way actually is to use one of your existing anterior segment OCT devices. You don't need to use anything fancier than that. This is basically showing the normal and abnormal architecture of meibomian glands in a patient with dry eyes. And of course, if you use a different version that employs something to assess that using AI software, you can actually grade or quantify MGD as well. You can also use the bulbar redness evaluation software on the keratograph. I don't find it to be very useful, really. It depends sometimes if a patient has had a long night. And of course, there are different things available, software available on machines that can basically look at this. I'll just skip through this. You can use confocal microscopy. If you have access to that, it's really useful, especially in patients who have rheumatological dry eye. This is from a normal patient, a patient with dry eye, and a patient from Sjogren's syndrome. You can see the size of the acinar units in patients with Sjogren's syndrome. Impression cytology is basically used mainly for research purpose. We use impression cytology a lot for our dry eye patients where we are planning to study the ocular microbiome in these patients. You can use the newly available or relatively newly available impression cytology devices where you really have sort of this plunger which goes into the conjunctiva and you can get a good sample and subject that. So to conclude that there's no ideal automated test. You really have to rely on clinical exam, proper history taking. You can use any of the available sort of devices to quantify the dry eye disease in your patients. Thank you for your attention.
Excellent talk, Dr. Jhanji, as usual. So, just I wanted to ask you one thing, that you have shown that in your articles that some patients with inflammatory dry eye, in confocal microscopy, sometimes or even in that specular microscopy, they are having less endothelial cell count. What's the reason for that?
Endothelial cell count?
Yes.
Yeah, I don't think they're supposed to have lower endothelial cell count. It might be, I don't know what you're going to use.
People are having this inflammatory dry eye for a long time. Now that impacts this endothelial morphology of all those things.
I'm not aware of inflammatory dry eye affecting the endothelium per se. I mean, there's something else probably going on along with inflammation, which is causing intraocular inflammation that can affect the endothelium. I don't know what the panel thinks.
No, he's right. So there is some evidence that patients with chronic, so the thinking is that it's a chronic neuroinflammation that's causing the dry eye on the ocular surface. So when you've got neuroinflammation, generally even in the stroma itself, there's some effect on the corneal endothelium. So Residena has a paper exactly showing that itself, where patients have slightly lower endothelial cell count when you compare it to normal. But these are in chronic patients, and often there's a neuroinflammatory response to the dry eye, the underlying pathogenesis of the dry eye disease. So it depends then what's the long-standing pathogenesis. But
yeah. And a good example would be, again, neurotrophic keratopathy. Those patients would definitely have some impact on the endothelium, but something else is going on as well.